Khamma Ghanisa, Namaskar, Namaste, warm greetings from Elchem Gastrochem Division. My name is Ankit Shah, and on behalf of Elchem Gastrochem, I extend a warm welcome to especially our distinguished faculties who are at the Jaipur Live Center, to our esteemed delegates across the 30 centers which are live from all over the country. In North, we have Delhi, Jaipur, Ghaziabad, Dehradun, Chandigarh, Lucknow, Varanasi, Prayagraj, Meerut, Bareilly, who have joined. From East, we have Patna, Gaya, Darbhanga, Ranchi, Bhubaneswar, Kolkata, Siliguri, Agartala, and Guwahati. From West, we have Mumbai, Pune, Ahmedabad, Bhopal, Nagpur, Nasik, Akola. And from South, we have Hyderabad, Bangalore, Chennai, as well as Vijayawada. So I welcome all the delegates, our distinguished faculties, and to my entire team live from Jaipur. Before we start, would want to welcome our delegates with a small bouquet. So if I can request Gaganji, our head of sales, to present the bouquet to our faculty, Dr. V.K. Kapoor, sir, our moderator and chairperson for today. To Dr. Vivek Saraswat, sir, our moderator. To Dr. Naresh Bhatt, sir. To Dr. H.H. Nag. To Dr. Manoj Kumar Sahu, sir. And Dr. T.D. Yadav, sir. So DIGEST. DIGEST stands for Driving Initiatives in the Field of Gastroenterology, Science, Education, and Technology and Treatment. This entire initiative of DIGEST has been envisioned for scientific dissemination. It's a pure academic platform for knowledge sharing and for sharing of best practices in the field of gastroenterology with the objective of superior patient care. I have this honor, and it's my deep privilege to speak and to introduce Dr. V.K. Kapoor, actually who requires no introduction. Sir is a pioneer and an authority in the field of gastroenterological surgery. Dr. V.K. Kapoor is the moderator and chairperson for today's Digest, brought to you by Elchem Gastrochem. Dr. V.K. Kapoor is Professor of Surgical Gastroenterology at Mahatma Gandhi Medical College and Hospital, Jaipur. He has been a former HOD and professor at the Surgical Gastroenterology at the respected and the renowned SGPGIMS, Lucknow. He is an authority for hepatopancreatobiliary and gastroenterological surgery with 4 decades of experience, clinical experience, surgical innovation, and of course training thousands of students under him. He has authored close to 150 plus publications, and there are textbooks and chapters in his name. He has been a pioneer, and he has taken every opportunity whenever it comes to academics. Sir has always been there, right in the forefront, and leading and training and sharing his knowledge in the field of gastrointestinal surgery. I welcome Dr. V.K. Kapoor to take it forward, and it's our honor to begin this first edition of Digest under his leadership, and request Sir to take it forward. Thank you so much.
Thank you, Ankit ji. This is, as Mr. Ankit pointed out, an initiative of Elchem, and because it is gastrointestinal initiative, it is the Gastrochem division of Elchem, and when both Ankit ji and Gagan ji discussed this with me, I said, yes, we will be willing and very happy to drive it. So the drive is from us. And I was very fortunate to have with me Dr. Saraswat in my institution now, and earlier for more than 3 decades at SCPGI, and both of us kind of agreed and volunteered that we will take the Digest initiative forward. Once in 6 months, we will hold a physical meeting like this, which will be transmitted live to, as was told, that today we are transmitting it live to 30 centers across the country. And the plan is that every month or every 2 months, we will have a pure online meeting. And we intend to cover various aspects, especially the controversial and debatable aspects of gastroenterology, both medical and surgical, with authorities on the topics from all over the country. So Dr. Saraswat, who had been the professor and head of the Department of Gastroenterology at SCPGIMS for more than 3 decades, and is currently the professor and head of hepatology at the Mahatma Gandhi Medical College and Hospital. And he has held the prestigious positions of honorary secretary and president of almost all gastroenterology societies related to hepatology and gastroenterology in the country. So with that brief background, we will start. For today's session, we have chosen 2 very common but very important topics. The first is asymptomatic gallstones. So we are not talking of symptomatic gallstones because there is no debate and controversy as to what to do. And second topic is that once a cholecystectomy has been done for a stone disease, symptomatic stone disease, and unfortunately there is a problem of bile duct injury and bile leak, what to do. So the idea is that we will have the discussion on the first topic first. We will have some discussion, and then we will go to the second topic. So with that, I would request Dr. Saraswat to introduce Dr. Bhatt, and then we will start the session.
Good evening, ladies and gentlemen. I'm very pleased to be involved with this academic initiative that has been started by Alchem's Gastrochem division on Digest, as you've just heard Mr. Ankit tell us. What you would like to do is to create a forum in which there is lively interaction, debate, and one of the ways to do that is to choose topics on which there is not complete consensus, there is some differences of opinion, so that the matter can be debated and discussed and carried forward. So on these lines, today's first session is on asymptomatic gallstones. A physician and a surgeon will be speaking on this topic, followed by the next one on bile leaks after cholecystectomy. Again, a physician and a surgeon giving their perspective, followed by Q&A. So please do keep sending in your questions as we go through the talk so that we can have a meaningful interactive session at the end. It's my great pleasure to introduce Dr. Naresh Bhatt, who's Chief of Gastroenterology at the Aster CMI Hospital in Bangalore. Naresh is a past president of the Indian Society of Gastroenterology, who is trained at St. John's in Bangalore and then at PGI Chandigarh, as well as in Germany and Japan. He is one of the most eminent gastroenterologists in this country who has great interests in teaching, in research, leadership of various groups, as you can see listed here, the Ann Big, a past president of the GI Endoscopy Society as well, and also now a president-elect of the AIGE, and the president of the Karnataka chapter of Indian Society of Gastroenterology. Numerous awards that are listed here. Extensive experience in both therapeutic endoscopy, inflammatory bowel disease, hepatology, and clinical gastroenterology. So with these few words of introduction, I'll request Naresh to come up and speak to us about his topic on gallstones and gallbladder cancer. Because that in asymptomatic gallstones is a major bugbear. People have this apprehension of gallbladder cancer, which drives decisions, maybe not completely rationally at times. So Naresh, please come over, the floor is yours.
Good evening, friends, and thank Vinay and Vivek for this invitation to be part of this all India kind of discussion on certain controversial issues. And the first they have chosen, not surprisingly, because actually Vinay has spent a large amount of his life working on gallbladder stones and gallbladder cancer. So without much ado, let me start my slide. Can I have the slide, please? So we're going to talk about gallbladder stones and gallbladder cancer. And it takes two to tango. Do you really need both of them? Let's look at some of the data before we have the surgeons talk to us on the role of surgery. So start off with a very basic question. What causes gallstones? There are several issues. One is, of course, the kind of bile that the liver makes. Then what is happening in the gallbladder? Is there gallbladder disease? Is there a lot of stasis or dysmotility in the gallbladder? And of course, there are intestinal factors that contribute. There's a background of genetic factors as well. This is largely for cholesterol stones. But as far as the pigmented stones, again, there's an increased production of bilirubin, bile stasis, bacterial infection, etc., which all contribute. So the players are multiple. It can range from problems within the liver or genetic factors. There can be gallbladder-related issues, and of course, other players outside, including the intestine. We know that gallbladder stones come in many shapes and sizes. We tend to classify them as predominantly cholesterol stones on the left of your picture here. And then you have the mixed, and finally you have the pigmented stones. Cholesterol stones are more common in the north of this country, while in South India, where I work, we see a lot of pigmented stones. So just by looking at the stone, we can predict what kind or what the possible content, and maybe even speculate on the etiology, because those of us who do ERCP and keep pulling out these stones recognize this. But it does not make too much of a difference for us when you remove the stones for biliary obstruction, but certainly makes a difference when we are dealing with more basic problems like gallbladder cancer. Now let's start at the very beginning. We know about asymptomatic gallstones, and this is an often quoted study, which is a Danish cohort study which went up to 20 years. And they found that a group of patients have complicated disease, which may be CBD stones, pancreatitis, acute cholecystitis, or gallbladder cancer. Uncomplicated, maybe about 12% actually develop biliary pain. So what does this tell us? It tells us one simple message, that even over a long-term follow-up, in their population, a majority of patients do not have a problem. So if they do have a problem, it's restricted to a small number, and hence, across the world, people have been practicing this business of not doing any intervention for asymptomatic stones and only coming into the picture when there are symptoms. So this has been widely accepted, and this is the prototype study. There are other studies which have come out, but largely it means that a small number will develop symptoms. When they develop symptoms, do something. If they do not have symptoms, you can stay quiet. Obviously, there are exceptions to this, and I'm sure my surgical friends will talk about these exceptions. But what about gallbladder stones and cancer? We recognize that a lot of patients who develop gallbladder cancer do have associated stones. So there is no doubt that there is an association between the two. But the data is a little confusing depending on which geographical location of the world that you're looking at. If you look at Pima Indians, right, and in South America, you find that they have a lot of patients who have gallstone disease, and they have a lot of patients with gallstone cancer, gallbladder cancer. If you come to the Caucasians in America, you find a lot of them have gallbladder stones, but the number of patients who have gallbladder cancer are not that many. Which means, while there is an association, obviously there are other factors which are playing a role. And if you look at India, it's even more funny. You have not so many people having gallbladder stones, but amongst them, the number of patients who have gallbladder cancer is extremely high. The only unfortunate thing which we don't have is a long-term study, a cohort study for several decades that would have given us much more meaningful information, but I'm sure we'll get that data sometime. So remember that there's an association between stones and cancer, but the actual number varies from different parts of the world. So is it a risk factor or is it an incidental thing? If you look at gallbladder stones, 80% of patients who develop cancer have gallbladder stones. There are only about 20% of them who perhaps have a different pathway and do not have associated stones but develop gallbladder cancer. So the vast majority in India, up to 80%, have stones in their gallbladder before they develop a cancer. So that association is so strong that you cannot ignore it. Is gallbladder cancer a bad disease? This is a picture from Vinay's article. Yes, it is a bad disease because gallbladder is extremely thin-walled. It has no submucosa at all. It's the mucosa and then the muscle. So any tumor that develops spreads very quickly through the muscle and invades the local structures. It's difficult to pick up. Surgery is challenging. Response to chemo and radiotherapy not very great, and the survival rates are poor. So before you know it, there is lymphatic spread perhaps into the liver that is very close to the gallbladder. So generally when we pick up, they are advanced and we can't do too much about it. So if it's a bad disease, I don't think we can wait for that disease to come. Do we really need to do something before they develop? The other problem is that if they are associated with gallstones, they're extremely difficult to detect. You can see the stones, but you can't see the early tumor. India has been thought to be a capital for many things. Diabetes, obesity, so on and so forth. But it's also known as the gallbladder cancer capital of the world. Actually, there are two areas, one down here in South American Indians, and then in India, where these numbers are actually very alarming. And as we discussed in the previous slide, in the West, you have a lot of gallstones, less of gallbladder cancer. Here you have a fair number of gallstones, but disproportionately more number of gallbladder cancers. And perhaps there are cofactors that are playing a role. Not only that, the age of onset is at least a decade or a decade and a half earlier. But India is one country, as we call it. But unfortunately, there are huge geographical differences within this country. We have so many languages, so many cultures, and there's so bound to be a difference in the epidemiology of gallbladder stones and gallbladder cancer. There actually is a north-south or east-west divide as well. And if you draw a line this way, this part of the country where I come from, we don't see too much of gallbladder stones or gallbladder cancers. We have more pigmented stones. But if you look at this so-called Gangetic belt and beyond, up to the Brahmaputra there, right up to the northeast, you see a lot of patients who have gallbladder cancer. In fact, if you look at the highest numbers have been talked about, this Kamrup urban district, then you have Delhi, Dibrugarh, Khasi, Imphal, etc., etc. But if you come down to the west, in Mumbai, Aizawl, Bangalore, the numbers are very small. So South and West India, the epidemiology is different, while it's different in the north of this country. Why is it so common in India? Stones, yes. But then the Westerners have stones, but they don't have that much cancer. So obviously something else is playing. And there are many factors here, right from typhoid carriers, H. pylori, socioeconomic problems, poor socioeconomic status, possibly pollutants, heavy metals, pesticides, gallbladder stasis, and so on and so forth. Hormonal factors, all may be playing a role, whether they're multiple, concurrent, additive, we don't know. But suffice it to say that we know the epidemiology reasonably well. How does it cause cancer? Why do stones just stones there? How does it lead to cancer? There are many, many factors. It may be a mechanical injury. Large stones, hard stones have been clearly shown to be associated with cancer rather than small, soft stones. So those are the usual cholesterol stones. So if you have someone with large stones, perhaps he has a higher risk. You have a bacterial factor where there's increased inflammation, proliferation, metaplasia leading to cancer. You have chemical factors as well. So there are many factors amongst the stones itself, the mechanical factors of the hardness or the size versus the bacteria and the chemical, all put together, creating an environment suitable for cancer. Again, stasis also plays a role. And in fact, there's a very interesting study done by Professor Usha Datta, who has been kind enough to lend me some of these slides which I have used in this presentation, is that they found that they took patients who just had a routine cholecystectomy and then subjected it to histopathological thing. What happens generally is that people just remove the stones, show it to the patient and say, I've removed the stones, give it to a bottle, patient is happy. In fact, there's a significant number of surgeons who don't even send that gallbladder for histopathology. I mean, that is shocking. But yes, Usha Datta and her colleagues looked at this and they found that a lot of patients, 50% of these patients, had pre-neoplastic features on the gallbladder, in the gallbladder wall of intestinal metaplasia, especially incomplete intestinal metaplasia, which is the worst kind of predecessor for cancer. So routine symptomatic gallbladders removal, they found these lesions. Really something which is very alarming. So to summarize, what is the gallbladder to gallbladder cancer story in India? Yes. First you have gallbladder stasis, leading to stones, all these factors perhaps playing a role. Then you have malnutrition, low socioeconomic status, gallbladder stasis again persisting over a period of time. Then you have other factors like age, the geographical region, H. pylori, smoking, etc., etc. So that over a period of time, which starts perhaps early here, over a period of time that they develop gallbladder cancer. So it's not just, it doesn't take two to tango, it needs a whole orchestra. And you have this, all these which are the supporting factors which drive to gallbladder cancer. So how do we prevent gallbladder cancer in India? Do we go and knock out all gallbladders in North India and Northeast India? Well, the surgeons would have a field day, I'm sure. But that's not a solution. So we'll have to find out something. Of course, if they have symptoms, you're very clearly justified in doing a cholecystectomy. If you're asymptomatic, what do? Can you just follow them up, keep doing ultrasound scans? And I said, it's not easy to pick up these early cancers when you have stone disease as well. There's so many of those stones with those shadowing and things like that. You can't make out that asymmetric wall thickening and things like that. Do we do a preventive cholecystectomy? Or do we build up some kind of strategy that you can select those with a high risk? Just select those, and some of the things that I mentioned are people who have large stones, especially the cholesterol stones, or patients who have a stone with a polyp, or in a geographical location where there's epidemiology suggests a high sort of prevalence, you do that. Or do you select out women who are obese, or people who are obese and smokers, or you actually show some kind of gallbladder dysmotility by doing, looking at the gallbladder ejection fraction, or how much it can sort of contract after getting a fatty meal, or those who have a biliary pancreatic ductal union disorder, congenital factors. So this is something that we have to discuss, and I'm sure we'll have that discussion later today. But the bottom line is that any prophylactic surgery in an asymptomatic patient has to be safe. We cannot have patients having post-cholecystectomy problems, leaks, bile duct injuries and so on, and still offer them prophylactic cholecystectomies. Neither are the patients or the physicians going to allow that. So I think we have to find out some way that we train our surgeons better or select patients better so that we get a good outcome. Thank you.
Thank you, Dr. Bhatt, for giving us an overview of gallstone disease and its relationship, I would say, with gallbladder cancer, and especially highlighting the Indian scenario. Now we will discuss whether and when to do a cholecystectomy to prevent gallbladder cancer in a patient, actually not even a patient, a person with asymptomatic stones, because she doesn't have any symptoms. And to cover this topic, I have Dr. H. Nag, who is my former fellow from SGPGI Lucknow and is currently the head of Department of Surgical Gastroenterology at the prestigious GB Pant Hospital, and who has special interest in gallbladder cancer. Nag, please.
Thanks a lot, sir, for kind introduction. I think we all have interest in gallbladder cancer because of you. It is as per your interest we are continuing on that. I'll try to discuss some scenarios where we can do prophylactic cholecystectomy in Indian scenarios. Our agenda, my agenda will be incidents which is already covered by Dr. Bhatt in this thing properly. I'll cover it just in brief, and I'll try to discuss about association of gallstone disease with gallbladder cancer as per some available studies. And is there any role of prophylactic cholecystectomy? Then this thing final takeaway. Incidence, as you all know, as per this World Federation Ultrasound of Medicine and Biology position paper published in 2024, around 10 to 20% of the overall world population harbors gallstone. But majority of are 60 to 80%, around 80% are the only gallstone carriers. They are asymptomatic. And annual incidence of gallbladder symptom initial 5 years as per the study is around 2 to 4%, and it reduces after that 1 to 2% per year. And however, it is increases with the time. And overall incidence of gallbladder cancer in all patients is around 0.01% to 0.2%, and long term more than 5 years, that is around 0.3% as per this study. This is another, according to for the epidemiology of the cancer, gallbladder cancer in India. Incidence, as my earlier speaker told, it is a gallbladder cancer is very common in India. It is a capital of gallbladder cancer. You can say 10% of the global gallbladder cancer burden is in India, and majority of gallbladder cancer patient has got gallstones, and gallstones increases vulnerability of mucosal injury, and this is the pathophysiology that already discussed by my earlier speaker. And this is algorithm by Ratnaswamy, Indian Journal of Surgery, published in 2012. Gallbladder incidentally detected by histopathological examination after open or laparoscopic cholecystectomy in 0.2 to 2.9% of patients. However, incidence of incidental gallbladder cancers is very high in India. It accounts around up to 40% of that is a problem with us, and this is mainly because of missed gallbladder cancer, not the true incidental gallbladder cancer. And odds ratio for gallbladder cancer in patient with gallstone disease, if stone size is larger than 3 or 3 centimeter, it is 10-fold higher than the general population. And any change in the pain characteristics should raise the suspicion of gallbladder cancer origin or development in patients with gallstones. Another study, it was around precursor lesions of gallbladder cancer, published in Cancer 1993. Total 162 patients with elective cholecystectomy were studied, and patient had enteral metaplasia and intestinal metaplasia, hyperplasia. Carcinoma in situ was in 2.9% of cases. Interesting finding was if hyperplasia was present in association with dysplasia and carcinoma, it was very extensive in these patients. Another study published from AIMS in Annals of Surgery that again studied pre-neoplastic lesion and loss of heterozygosity in tumor suppressor genes. There was no association with the size of the stone. However, stone size they compared less than 1 centimeter and more than 1 centimeter, and single and multiple stones were not significantly associated with. There was no difference in these for the metaplastic lesions. You can see normal. 12 patients had normal gallbladder, and there was no precursor lesion. Other patients with gallstone disease had significant number of precursor lesion, and this thing 0.6% was the incidence of carcinoma in situ, and there was a significant age difference in patient with dysplasia and cancer. So with the with the increase in age, cancer incidence increases in patient with dysplasia. Another study published in Annals of Surgery 2016 studies more than 2,900 patients and compared with 75 patients with gallbladder cancer. 8% patients who were older than 50 years and had gallstone more than 1.5 centimeter size developed gallbladder cancer, and it was significant. Time to develop carcinoma was 6.3 years in patients with adenocarcinoma, and it was significantly longer in patients who develop squamous cell carcinoma or adenosquamous carcinoma. Gallbladder cancer size 3 centimeter versus 1 centimeter had odds of developing 10-fold higher odds of developing gallbladder cancers. So high risk group contain more than 3 centimeter size and long standing gallstone, especially cholesterol stone, has constituted the high risk factor for the development of gallbladder cancer. This study from STVGI under Professor Kapoor. In this study, we studied what are the other factors associated for the development of gallbladder cancer in addition to gallstones. Overall incidence of patient with gallstone developing gallbladder cancer was 1 to 3%, and around 70 to 90% of the gallbladder cancer patient had gallstone. In addition to gallstone, other factors were involved like old age, low education, patients who were frequently daily drinking hand pump water, and multiparous women. However, some factors were protective also, like coffee intake, sweet intake, and antihypertensive drugs. When we are talking about prophylactic or preventive cholecystectomy, we should also discuss about the post-cholecystectomy complication. Few Korean and Chinese studies has reported that patients who had cholecystectomy had increased risk of non-melanoma skin cancer, and some patients had a reduced risk of small intestinal tumors. Korean study published in 2022 found that it is high incidence of leukemia and malignancy like colon cancer, liver cancer, and pancreas. Another study also pointed out gastric cancer incidence was higher after post-cholecystectomy. In addition to that, there are so many post-cholecystectomy complications. Most important is bile duct injury, which is very common, and post-cholecystectomy diarrhea and other complications that should also be considered while we are considering patient for the prophylactic cholecystectomy. Now, when to do? This is the study pointed out some factors for indication for prophylactic cholecystectomy like APPDJ, choledochal cyst, gallbladder adenoma. Some regions where incidence is high, porcelain gallbladder, choledocholithiasis, gallstone size larger than 3 centimeter, hemolytic diseases, patients who are on immunosuppression, and younger age of detection of the asymptomatic gallstones. This is another study. They have pointed discuss about what is the benefit of the prophylactic cholecystectomy. They pointed out few conditions where we can have beneficial benefit of prophylactic cholecystectomy, like patient who are undergoing transplant has got pre-transplant cholecystectomy has got significantly lower risk morbidity and mortality in comparison to if we do the cholecystectomy after this thing. Similarly, patient of NET who is planned for the acute therapy can benefit, and what are the risk of asymptomatic gallstone. If patient continues to have gallstone, will develop, some patient may harbor polyps in other 6 factors and then may go on to develop the gallbladder cancer later on. And patient with recurrent episode of inflammation will have the acute complication like acute cholestasis, cholangitis, and outcome may be inferior in these patients. Severe inflammation, chronic inflammation, and fibrosis will make cholecystectomy difficult, and complication rate may be higher in these patients. So they propose that we should not be propagating cholecystectomy or deciding for the patient. We should explain patient everything, and patient should have autonomy to decide about whether they want to have cholecystectomy or not. EASL guideline proposed there is against the blanket cholecystectomy for the generalized recommendation for the cholecystectomy as because of it is not cost effective and in Western population risk is not as high to recommend the prophylactic cholecystectomy in most of the patients. In contradiction to that, one Indian study proposed that in Indian scenario, one gallbladder cancer could be prevented by performing only 67 cholecystectomy in high-risk areas versus 769 cholecystectomy in low-risk areas. So it can be considered a secondary prevention measure in Indian scenario. I will focus more on the ICMR guideline. Professor Kapoor, Professor Sahni, and Professor Shukla were the part of these committee who formulated these guidelines that summarizes the most of the scenarios that should be considered for the prophylactic cholecystectomy. There is no confusion. Symptomatic cholelithiasis patients should undergo the cholecystectomy. Gallbladder polyp size 1 centimeter or larger should undergo cholecystectomy. Patient who has got sessile polyp and other characteristics are going, a patient who has got size of the polyp is growing or heterogeneous enhancing, and where there is length and width ratio is less than 1 should also be considered for the prophylactic cholecystectomy. All patient who has got APPDJ has got around 10% incidence of the 10% patient of gallbladder cancer has APPDJ, and around 10 to 40% or 15 to 40% patient of APPDJ may have the biliary tract cancer. So these patients should be considered for the prophylactic cholecystectomy with or without CVD excision, as there is risk of biliary tract cancer also. Most of the patients will be having choledochal cyst also. Porcelain gallbladder, initially it was considered as a high risk case, but now evidence is arising. All cases are not as high, contains as high risk as it was considered earlier. Only when porcelain gallbladder calcification is partial and speckled, then that is a high risk case, and we should consider patient for the prophylactic cholecystectomy. Asymptomatic gallstone in high risk cases may be considered for the cholecystectomy, and young age patient with large stone and where gallbladder packed with the stone in high incidence areas may be considered for the preventive cholecystectomy or may be kept on the surveillance also, depending upon the patient choice. So gallstones are the important factor for the development of gallbladder cancer. But we have to select out high risk cases as I enumerated. Rest patient should decide about their treatment, whether they want to have this thing, prophylactic cholecystectomy, or they want to continue with the surveillance. In last, I can say gallbladder stone may cause gallbladder cancer like tobacco can cause cancer. Rest lies with the patient. Thanks a lot. Thanks, Dr. Jessica, for the preparation of the slides.
Thank you, Dr. Nag. I must admit that there is no evidence to say what should be done in an asymptomatic gallstone. No evidence, no recommendation as far as India is concerned. West, there are recommendations, but then we know that gallbladder cancer is a geographical disease. As was highlighted both by Dr. Bhatt and Dr. Nag, the incidence rates of gallbladder cancer in India are at least 10 to 20 times higher than in the Western population. So since we do not have evidence in India about the natural history of asymptomatic gallstones, there are no recommendations. So what I'm going to say is basically an opinion, my opinion, based on whatever little I have understood about gallstone disease and gallbladder cancer. There is no doubt that there is an association between gallstones and gallbladder cancer, because in our patients, experience from Lucknow, GB Pant and other hospitals, 70%, about 70%, 60 to 80% of patients with gallbladder cancer have stones. But at the same time, 30 to 40% do not have stones. So gallstones do play some role, but whether gallstones cause gallbladder cancer, we don't know. And we also saw that there are populations where the prevalence of gallstone is high, but the incidence of gallbladder cancer is very low. So is it that stones cause cancer in some populations but not in the other populations? Is it that some type of stones cause gallbladder cancer and other type of gallstones do not cause cancer? So we don't know this. Now, if we do not remove an asymptomatic gallstone and the patient is in a high incidence area, there is a risk that patient may develop gallbladder cancer. And we all know that it is very, very difficult to diagnose early gallbladder cancer on ultrasound, which will be the surveillance modality, and even on CT or MRI, which you would not do when you are following up a patient or a person with asymptomatic stones. So by the time the cancer is detected, it will usually be advanced. And we all know how bad disease a diagnosed gallbladder cancer is. So it is an unpredictable risk, it is an uncontrollable risk, and once cancer develops, it is going to be a very poor outcome. So that is what is at the back of your mind, that is what is there at the back of the patient also, if the patient has gone through information available on the internet. On the other hand, if we do a cholecystectomy in an asymptomatic person, and there is a complication, and the most dreaded complication, other than the long-term risk of some cancers, the immediate complication that we all surgeons are worried about is the bile duct injury and bile leak, which again, it is very well established, the risk, overall risk is about 0.5%, 0.3 to 0.5. That means 1 in 200 to 300 laparoscopic cholecystectomies, there could be bile duct injury and bile leak, which is a significant, and it is an immediate problem. Gallbladder cancer developing is a remote issue. This is an immediate problem which will happen the very next day. So what to do? In such situations, two things are very, very important. Whichever approach you take, I am not going to recommend any approach of these two. Whichever approach you take, you have to counsel the patient very well. If you are not operating, you have to tell the patient that, look, there is a small risk that you may develop gallbladder cancer in future, and then the patient should not come back to you and say, why did you not advise cholecystectomy? On the other hand, you have to tell the small but definite risk of injury also, and that is where the last slide or the last statement on the last slide of Dr. Bhatt is very, very important. All cholecystectomies should be safe, but definitely cholecystectomy in an asymptomatic gallstone has to be 100% or 101% safe. And it has to be done by an experienced surgeon who takes extra care to make the cholecystectomy safe. The subgroup, if the patient is young, 20-year, 30-year-old female, who is now going to remain exposed to this stone for the remaining 60 to 80 years of her life, because duration of gallstone disease is also a risk factor. A large stone, 3 centimeter is the cutoff, gallbladder packed with stones, where the stone gallbladder volume ratio is almost 1, that the entire gallbladder is full of stones. These are factors which probably would push you towards advising a cholecystectomy rather than a older patient who comes to you at the age of 50 or 60, small stone, the gallbladder is filled with bile and there are few stones in the lumen where the risk probably would be lower. So if you have to choose, that is what you can choose. And to the young colleagues here, this is an area of research for future. We should try to find out that whether there is some other marker, blood-based, saliva-based, urine-based, which can predict a high risk of gallbladder cancer in an asymptomatic gallstone, because then you can sub-select the group of asymptomatic stones, type of stone. Now, the type of stone can be studied by in vivo by MR spectroscopy. So is it a type of stone which predicts a higher risk? So these are areas for future research. So again, I would say there is no evidence, there is no recommendation as to what should be done for an asymptomatic gallstone in India. This is my opinion, that if these are the two options, whichever option you take, you have to take these precautions. Thank you. Dr. Saraswat.
Thank you, Professor Kapoor, Professor Bhatt, and Dr. Nag. You've all given an excellent overview. I think there is very little left for me to add after the considered opinion that Professor Kapoor has told you, but I'd like to bring 3 or 4 points to your attention. And the first being that, as we have all heard, there are high prevalence and low prevalence areas for gallbladder cancer. And gallstones, although the frequency is not that different to justify that only gallstones cause it. So obviously the other factors that contribute to the development of gallbladder cancer need to be identified in greater detail. Why is northern India different from southern India is possibly related more to these additional factors of infections, of chemical exposure, toxins, which is something that we should explore further in the context of gallbladder cancer. Not that we do away with the gallbladder, but how do we manage these other risk factors that are identified and try and eliminate those, so which should have a role in the control of gallbladder cancer. Similarly, while we all say high prevalence, how exactly high is the prevalence? How accurate are our data to say that in high prevalence areas, this is the risk? 1 to 3% as one of the SGPGI studies showed, or 0 to 0.3% as the Western data shows. So this is a matter of data gathering and collection, which I think with so many people interacting and interested in this common problem between different regions of our country, it should be possible to generate our own data. I think Professor Kapoor has talked at ample length about the risk of bile duct injury. Whenever prophylactic cholecystectomy is being done, that is the major consideration. And given whatever limited data we have about prevalence of gallbladder cancer, so to prevent one gallbladder cancer, if you take it between 0.3 and 3%, that is to prevent 3 to 30 gallbladder cancers, you have to risk about, and I'm taking this for lap chole from a well-published reference, that bile duct injuries can happen in 0.3 to up to 2% of patients undergoing lap choles. So to prevent 30 cancers, or 3 to 30, you get 2 to 20 bile duct injuries, which is the data that we have from Western extrapolations. Again, as Professor Kapoor has been working very much in this area, the bile duct injury data is very opaque in our country. Nobody wishes to share how much injury is caused or what is happening. So we are kind of having to work in a vacuum, trying to calculate the exact risk or problems that may be associated with prophylactic cholecystectomy. As you know, in Chile, in South America, which is probably has the highest prevalence of gallbladder cancer in the world, they have done epidemiologic studies based on the population and based on mapping of gallbladders taken out at routine cholecystectomies, and come to a conclusion that the risk of cancer is so high that prophylactic cholecystectomy has been advised as a national policy in Chile. This is based on data, but we are nowhere in our country in trying to generate these kind of data. See, a mathematical modeling of what is the risk of gallbladder cancer, what is the risk of bile duct injury, and individualizing it to a population in a high risk or in a low risk area, what could probably be the way forward. But the nodes of any Markov analysis or any mathematical modeling need to be filled in with reliable data, which may be regional. It may be East India, Northeast India, Northern India, and so on, and we can construct this. So I think if any purpose is served by this meeting today, it would be to drive home the fact that all of us who are dealing with gallstone disease need to figure out and support efforts, including what Professor Kapoor has been doing for years, to try and generate data on bile duct injuries and on gallbladder cancer prevalence, and based on that come up with rational projections that we can offer to our patients rather than leave it to the patient. भाई कैंसर भी हो सकता है, bile duct injury भी हो सकता है, अब आप बताओ क्या करें. No, the patient is not the authority. You are the authority, and you have to recommend a choice of a course of action. The problems we have in articulating a clear opinion, I think Professor Kapoor has elaborated at length, which I will not go over. So the problem remains that the solution to that problem is only generating as good and as much data from our own country and from different regions of our country as we can, which will help us to come to a more refined recommendation in the course of time. Thank you very much. I think we now move to the next part of our program, which is to do with the management of bile duct injuries. And in this sequence, it is my pleasure to welcome Dr. Manoj Kumar Sahu, who is the director of KIMS Super Speciality and Cancer Hospital in Bhubaneswar, and they also head the Department of Gastroenterology there and is a senior consultant at the Apollo Hospitals in Bhubaneswar. Dr. Sahu has great expertise in therapeutic and interventional endoscopy, hepatology, and gastroenterology. Before joining KIMS, he was heading the Institute of Medical Sciences and some hospital also in Bhubaneswar. He's very involved in the teaching and training of postgraduates and fellows, particularly about endoscopic, advanced and endoscopic and hepatobiliary techniques, has published numerous papers, and has been instrumental in elevating the standards of GI care in Eastern India. With these words, I'll request Dr. Sahu to come up and talk to us about bile duct injuries.
Thank you, sir. Respected, esteemed moderators, like our teachers, seniors and friends, I am thankful to Team Alchem for the opportunity. We'll be speaking very briefly on bile leak after cholecystectomy, as we discussed now, and the endoscopic intervention. I'll be talking very briefly on the timing of ERCP, MRCP before ERCP, and the comparison between stent versus ENBD, that is nasobiliary drain. As you know, bile leaks is a common complication after cholecystectomy. In spite of tremendous development in surgical technology, still the incidence is not declining after laparoscopic cholecystectomy. Management overview, as we know, endoscopic management is the primary therapeutic approach, and the success depends on the type, location and timing of the bile duct injury, which is important. Proper classification of the injury and early assessment both are crucial for optimal outcome. And the approach should be individualized with multidisciplinary team involvement. The pathophysiology, as you know, most leaks originate from the cystic duct stump. We do have leak from other sites also. Classification is low grade and high grade. You know when to tell low grade, when to tell high grade. There are multiple classification systems of bile duct injury, but the most common which we use, which is most popular, widely used, is Strasbourg-Bismuth classification. If you see the imaging modality, we do have various imaging modality, including ultrasound. Ultrasound do have the sensitivity in various studies which is less than 60%. Among various modalities, MRCP is considered is an ideal diagnostic modality when you are suspecting bile duct injury or biliary leak. The role of MRCP before ERCP. Non-invasive visualization. It is ideal for initial assessment in hemodynamically stable patients. It will give a beautiful picture. Precise leak localization. The leak, bile duct leak, very precisely can be localized. It differentiates between low-grade, high-grade leaks. It helps exclude other associated complications associated with the bile duct leak. Strategic planning. Endoscopists to plan targeted therapeutic intervention based on the imaging finding in MRCP. Though ERCP is considered as the gold standard, it remains as the definitive protocol. Suppose a patient is coming to you which is very unstable with signs of peritonitis, sepsis. We need to directly proceed to ERCP. We may not wait for MRCP. So these are a few pictorial depiction of bile duct injuries. The principles of endoscopic treatment. What is the goal? The goal is reduce transpapillary pressure. The sphincter of Oddi, the pressure is 10 to 15 millimeter of mercury. When it contracts, it can go up to 150 millimeter of mercury. The most important is reduce transpapillary pressure. What are the techniques? The techniques which we follow very commonly are endoscopic sphincterotomy, biliary stent placement, and ENBD or nasobiliary drain placement. The treatment choice is guided or dependent on the leak grade, what is the grade of leak, ductal anatomy, and patient condition. Timing of ERCP, when to do ERCP. The decision when to do ERCP depends on clinical stability, drainage output, infection, and imaging finding what you are getting from MRCP. Prompt intervention is extremely important because prompt intervention depicts, it decides about the outcome. The outcome might be better and it prevents complications. If ERCP is delayed beyond 3 weeks, this is a very recent data, if ERCP is delayed beyond 3 weeks, it is associated with higher risk of stricture development. So this is the very recent study, early versus delayed ERCP. This is the retrospective study. If you are doing ERCP for bile leak within 3 weeks, associated with the higher success rate and lower development of biliary stricture within 3 weeks. Urgent ERCP, when the clinical situation demands, when the patient's clinical deterioration is there, sepsis, worsening peritonitis, uncontrollable biliary collection, we need to decompress the biliary system immediately. It is done within 24 hours. And different modalities, as you know, we put stents. There are situations we put a nasobiliary drain and we do sphincterotomy also. There are advantages, disadvantages. This is the comparison between stent and ENBD. We know most of the bile leaks we put stent, but in situation when there is high-grade leak, when there is associated coagulopathy, difficult to do a sphincterotomy, etc., we consider putting a ENBD. The selection consideration of the modalities, as I discussed, it depends upon the leak severity, duration of drainage required, how much duration we are expecting, and the associated comorbidity. This is the systematic review which compares between stent and ENBD. In this study, they found there are comparable risk of the comparable resolution of leak. But the choice between putting a stent or ENBD should be individualized. We need to balance the leak severity, patient preference, associated comorbid condition, and expertise, available expertise. Endoscopic technique, we do stenting. Stenting with or without sphincterotomy has a better outcome as compared to sphincterotomy alone. So we need to consider stenting, which is an important modality. We need to consider putting a NBD and bridge the leak in patients with underlying coagulopathy and when the leak is significantly more, when we want to assess the leak. fully covered metal stents serves as a second line treatment for patients who do not respond to plastic stent. Whichever guideline, recent guidelines are available, so they are describing, they are recommending the fully covered metal stent we need to consider when there is a no response after plastic stent, and the success rate is pretty good. But they are also describing we need to reserve this approach, putting a fully covered metal stent in patients with high-grade leaks, high risk for bleeding who are unable to undergo multiple ERCP sessions. This is a beautiful modality. Sphincterotomy alone is not frequently used but can be reserved for low-grade risk. But we combine sphincterotomy and stenting both. Stent diameter. This is a study comparing different sizes of stent. Stent size, this study they found does not affect the outcome, but this study is done in patients with minor biliary tract injury. We need to have good data on larger cohort patients. We need to have data on major bile duct injury. But when you are putting a stent, we consider the diameter of CBD before putting a stent. Bridging stent, this is a meta-analysis. They found when you are able to bridge the site of leak, the highest likelihood of healing biliary leak. And there is a beautiful, we can put a fully covered metal stent, effectively bridge the site of leak. This is the study they are recommending. So fully covered metal stent for early definitive endoscopic management. So early use of putting stent in the higher grade of biliary injury, high volume bile leak, this can be considered, but the recent guideline does not recommend putting initially. This is a study that usefulness of intraductal dumbbell-shaped fully covered metal stent. This stent need to be put inside the bile duct. So very good success rate, complications rates are little lesser compared to putting the common type of fully covered stent. When ERCP is not feasible, we are not able to go across the bile duct, not able to go pass across the guide wire, across the leak, we can take help of US. You can do a US guided rendezvous technique and perform ERCP. We can do a integrated stenting. There are few papers putting plastic stent and fully covered metal stent. We can do a transmural drainage also. This is the very recent study, US cholecystectomy for management of bile duct injury after cholecystectomy. They put plastic stent here in this study published very recently. This is the combination of ERCP and US. In some scenarios, their situation may not be great with performing an ERCP and going across and putting stent. So this situation, US can be a greater help. So we can combine both modality. There are some initial studies, they found this can be effective modality in difficult situation. Biodegradable biliary stent, this is the comparison with plastic stent. Efficacy is same, no need to do another endoscopy to remove stent. But there is a study of biodegradable stent also, but the problem is availability and the cost. Cost is little bit higher now. So in some situation, we may consider doing a percutaneous endoscopic rendezvous procedure for management of bile duct injury. This is the study, they found good success rate. When you are not able to go across, both combined, we can do percutaneous rendezvous. Transected bile ducts looks difficult for endoscopic management, but this is a combined percutaneous endoscopic approach involving the interventional radiologist. It can be done. Refractory leak, when after putting plastic stent, etc., no response, the leak is continuing. So there is a beautiful study now. We can consider putting fully covered metal stent and bridge the leak, and the response is pretty good. And there are few studies also they are doing. They're putting multiple stents and different sessions, and the response also very good, more than 90%. What is the evidence? The overall success rate is 93%. Excellent safety profile. The healing time, if you see the low-grade leaks, 2 to 4 weeks. High-grade leaks usually take little longer time, 4 to 8 weeks. Cystic duct leaks, they generally heal faster. So this is a study from India. So different etiology of bile duct leak. All patients are managed with ERCP. Complete symptomatic resolution is very good. Another study from India, this a single hospital study, they found also success is good managed endoscopically. Biloma can be drained by ERCP-based transpapillary drainage or US-guided drainage. This is a 54-year female, 7th post-op day after laparoscopic cholecystectomy, and we found cystic duct stump leak, initially managed conservatively, and by day 10, there is a persistent biliary drain, the drainage remains. We consider doing ERCP on day 12 by endoscopic sphincterotomy. We put a stent, drain output decreased within 48 hours and removed by day 14 and stent removed at 6 weeks and patient is asymptomatic. So ERCP is the first line modality after bile leak, after post-cholecystectomy, very good success rate. Urgent ARCP we need to consider when the clinical situation demands. Yearly ERCP, this is the recent data, yearly ERCP less than 3 weeks improves outcomes and reduces stricture development. MRCP is beautiful modality, it is valuable initial imaging tool. Drainage stents, for most cases we put stent, and NBD we need to consider in different scenarios as I discussed. Sphincterotomy adjunct need to be considered with this modality. If the bile leak is insignificant, very less, sphincterotomy alone can be beneficial. And very important is we need to involve other specialty. It is a multidisciplinary involvement for treating a patient of bile leak, and the treatment should be individualized. And there are recently tremendous developments are happening in the field of US. We do have many beautiful accessories now, and probably we are expecting in future endoscopically we can able to manage difficult scenarios also, difficult patients also. Thank you very much.
Thank you, Dr. Sahu. I think the surgeons in the audience should keep this very important point in mind, that the treatment of choice, initial treatment of choice for a post-cholecystectomy bile leak is by endoscopic intervention, and that is important, that if I'm doing a cholecystectomy at a place where endoscopic facilities or expertise are not available, and unfortunately I have a bile duct injury or bile leak, after stabilizing the patient, I must promptly refer the patient to a place where this facility exists, because if I don't do that, it may amount to negligence. It is very well established. Second important thing, which I'm sure Dr. Yadav will cover, is that before we do the endoscopic intervention to stop or to reduce the ongoing bile leak, draining the bile from the peritoneal cavity is very, very important. Because it is not the level of injury, it is not the extent of injury, it is not the severity of injury which kills the patient. It is the presence of bile in the peritoneal cavity which kills the patient by causing sepsis and multiple organ dysfunction. So that is the first step, and then next step is the endoscopic management. Now we know that endoscopy is a big help to us if a complication occurs in the form of a bile duct injury or bile leak. But then most of the cholecystectomies that we do, we don't leave a drain. Drain is not required. So how do we know that there is something wrong inside? That is the most important issue, the diagnosis, the suspicion. And to tell us that after a cholecystectomy, when to suspect that there is a bile duct injury and bile leak, and then what to do before we go for endoscopic intervention, we have Dr. T.D. Yadav. Dr. T.D. Yadav again is my former fellow from SGPGI, and he is currently a professor of surgical gastroenterology and a liver transplant surgeon at the prestigious PGI MAR Chandigarh.
ये वाला लाइट कम हो सकता है क्या? Namaskar and very good evening. So I am very happy that there was a discussion about asymptomatic stone, and if we are operating all patients with asymptomatic stone, are we ignoring the bile duct injury? And to our experience, people say that bile duct injury is decreasing because people are getting more and more experienced in a lab colleague. To my, what is our perception, that it's not decreasing till now. We don't know what is going to happen later. So bile duct injury, which is any procedure which takes popularity. If you are a poor man, you are left with no option but whoever is available in the local area. And that is the reason that my philosophy is that, and the way we are seeing bile duct injury patients, again, bile duct injury is also a disease of the poor. And a poor man goes whatever facility is available, and that's why bile duct injury occurs. So I think it's very difficult to suggest that this particular gallbladder will not going to have bile duct injury. So now I think my time is starting now because sir is very particular about the timing. So we can just go with this very interesting article. And Kenneth D. Lelimo has given his editorial comment in a publication by another guideline, multi-central guideline has been described, given by NHS regarding the safe cholecystectomy. In that comment, he has said, bile duct injury elimination, can we get to that place? And at the end, the inference is that it's very difficult, almost impossible. So coming to my topic, things to remember for us as a person when there is a bile duct injury, that prevention is the best management of bile duct injury. First surgery, whatever you do, is the reoperative I'm talking about, is the best surgery. Number of reoperations make surgery very, very more complicated. Reoperations are associated with the increased chances of failure, and restrictures are more common with the same surgeons doing hepatico-jejunostomy. Early, timely referral to a tertiary care center saves life and helps the society and cost. The outcome is best with the HPV surgeon. With these remarks and notes, I am going to talk about how to diagnose, as sir said, very typical topic has been given, how to diagnose the bile leak. And I start with the on table because recognition on the table is the most important, because complications and long-term morbidity and other cost, everything decreases significantly if bile duct injury is diagnosed on the table, wherever you are working. So prepared mind you need. If you don't have a prepared mind, you might not be able to diagnose the bile duct injury on the table. So if you are seeing a cyst, you are dissecting and you are finding that one tubular structure, you have cut it, then you are going and finding another tubular structure. You say that this looks like a duct of Luska, some insignificant duct, something like that, or this is the second cystic duct. So that cystic duct is the main cystic duct. The duct you have clipped earlier is the cystic duct. So never and never think that there is a second cystic duct. Second cystic duct is the duct which you have clipped is the common bile duct, and which you are now clipping is the so-called second cystic duct. So this is very, very important to know, and that's why it is after that what happens that you have see the color of the bile. What happens that a patient you have cut, you can see that clip has been applied here and cut. After cutting, there is a golden bile. So this golden bile is coming. Color of the gallbladder bile is usually blue. Color of the duodenal bile is usually green. So here is the patient that most probably bile duct has been cut. But if you are not ready to accept that, you will not even try to think. Then second important is, after the cutting, you see that what is the lie of that tubular structure. Is it dipping down or it is just perpendicular? So it is dipping down toward the duodenum. It means the lower part is the duodenum. And then another very important issue is size of the clip. If you are requiring 1 centimeter clip one after another, it means you are clipping the bile duct. So at no point of time 1 centimeter clip should be applied unless you are more than 100% sure. So this is the very, very important. Now compare the first picture with this second picture. You could see that lie of the duct. You could see after you have cut the cystic duct, the direction of the cystic duct, when after cutting, it is not dipping down. It is just perpendicular to the axis of the common bile duct. And you could see the size of the cystic duct. So this one is normal, and this one what we saw is the problem one. You could see again, just for the younger generation, you could see that by clip, direction, and after cutting. So these are the three important points which tell you on the table that something wrong has been done. Then after cutting, usually we cut the specimen. And if you are cutting the specimen, you are finding two lumen, it means that bile duct has been cut. So this is very, very important. And then once on table you have recognized that bile duct has been divided, then what to do? So there would be a scenario that you apply the clip, but you have not divided. You recognize that clipping has been done. And another scenario would be that you have divided, then you are diagnosing. So if you have not divided, then just remove the clip. You might ask later on to your medical gastro colleague that put a stent. Later on, if there is some sort of stricture occurred because of the clip, it might be taken care of by the gastroenterologist. So this is very important. Drain may not be required. Then after the division, you have two very important scenarios. Are you working in a hospital which is at the periphery, or you are working in a hospital which is tertiary care center? Injury can occur everywhere. Are you having a backup of the HPV surgeon at that particular center? Whole management will be different if you are having this thing. In a small hospital, what are the things you should do? Gallbladder, if not removed, please don't remove it, because the chances of more grievous bile duct injury occurs once you are trying to remove the gallbladder. Drain and refer is the best policy. Document the injury honestly, have a meeting with the patient relatives, and it is very desirable to refer the patient and talk to the person to whom you are referring. This helps you later on in patient not going to the consumer forum. The most of the time, patient going to consumer forum, they tell us that I was not told anything about the bile duct injury. So this is very, very important. Then what you should not be doing at that particular time, don't try to clip the superior part or try to push a tube inside that. Don't try to insert a tube. Don't hide anything in documentation. And most importantly, don't panic also. Because this can, if you have done everything right, there is enough evidence in the literature that injury can occur in any hand. And in the court of law, you will be saved. So this is very, very important. Then coming to scenario one. As I said, best is whatever I have told in a periphery where there is no backup. Now coming to scenario one. Golden expert is available. Bile in the field. When you have expert available, bile in the field, confirm that there is no injury. 100 times, 100% you have to be sure that there is no injury if there is a bile. If GB not removed, look at the specimen as I suggested. Assess the extent of the damage. Here you have to go a little bit extra. You assess either by doing a lap also, or you can convert it at the same time. Then extent of the damage, you can do a cholangiogram. If you are expert, you can do lap cholangiogram or convert and do a cholangiogram. This is very, very important. And when you are converting, don't go for a smaller incision in a compromised situation. You tell everybody, put bigger incision, because here you have done some damage in a big exposure. So meaning laparoscopy is not a smaller incision, it's a big incision. Because you are seeing everything big. Here you are going with a smaller incision because you are thinking that my patient will say, what a huge incision. The most important is that patient now should have a best outcome. And best outcome will occur only when you are doing the right thing. Then type of injury, try to assess there on the table. Then what to do? If you are doing all these things, then what you have, your morbidity will be decreased, there will be lesser hospital stay, and cost of the operation will be, cost of management will be decreased. Now, after conversion, you are finding a very small, less than 3 centimeter sectoral duct injury, ligate or clip it, there is no problem. If it is more than 3 centimeter, it means it is draining a very significant. And then on the table, you can do a cholangiojejunostomy or cholangioduodenostomy, I will not talk about. Here would be another scenario I will show you in my sketch, that in a cholangiogram you are seeing that the part which is seeing, you can have these two type of sectoral injury. So if it is communicating, nothing is required, even if it is more than 3 millimeter. But if it is not communicating, it means this particular segment is not communicating with the main segment. Here you will require some sort of drainage procedure. Now, second important is common hepatic duct or common bile duct injury. Lateral injury, if it is there, if you are expert, there is no thermal injury, there is no tissue loss, there is nothing, lateral injury, vascularity is not compromised. You put small, take a 6 OPDS, you can do a primary repair. In a liver transplant it can be done, or put a very thin tube and then come out. If you are doing primary repair, you be ready to put a stent and later on it can be dilated. If there is a total transection, then you have to see that is there a tissue loss? Is there a, what about vascularity? If there is no tissue loss, if there is good vascularity, you can still go for end-to-end repair. The only precaution when you are doing end-to-end repair that when you are doing end-to-end repair, don't try to insert the tube, a hole, make a tube out with the same repair place where you have repairing. Repair it and take either supra repair or infra repair, take the tube out, very small tube, and then this primary repair can be done, and it has been found that about 90% of the people are stricture free in primary repair. Again, caveat is that, are you using magnification? Because usually, normally it is less than 6 millimeter. Are you well versed with the sutures which are available, monofilamentous, 6 OPDS and magnification? If it is there, then it can be done like a transplant, there is no issue. And if some stricture occurred, it will be a hourglass stricture and it can be dilated. So message is that end-to-end anastomosis can be done, as I said, provided there is a clean injury, there is no tissue loss, there is no crush, there is no thermal injury, 6 monofilamentous suture can be done, preferably magnification to have a best outcome. Restricture rate is more than another option, which is hepatico-jejunostomy. Going above to the left duct and doing hepatico is the most preferred. But you might not be wanting to do at that time. So recognize in the post-operative period, what sir was saying, this one is the most common one, which is most difficult, and it is most common and most complex and most controversial. This is the, because, so how will we suspect bile duct injury? As sir said, there is no drain, usually not drain is not put. Then what happens? We call it unexpected recovery. What is unexpected recovery? Patient next day should be up and about, going home, talking, taking food. There should not be nausea, not a significant pain. Very small amount of pain can occur at the port sites. If something happens beyond that, means he's not ready to eat, he's not feeling well, if there is a pain which is not expected pain, and any sort of tenderness, or he's telling some tenderness, or if on examination you are finding some sort of localized, some guarding, then there is extra investigation is not going to do any harm, that you at least one ultrasound and LFT must be done. If there is a drain which is not kept, then bile can be in the drain. If there is no drain, even sometimes you can find little bit of bile tinge at the port site. So if all these things are not occurring, then as I said, there are some sort of warning signs. What are these warning signs? Unusual pain, uneasiness, tachycardia, if it is going more, tachypnea, tender abdomen, and bile at the time of the port. These are the very warning signs. And what you should do? There should be a very low threshold for the CT scan. Ultrasound may be very, very non-informative. It may be little bit of fluid fluid inside the loop. So that is not important. Important is once all these things is there, you go and do a CT scan. And in CT scan you can see these are the perihepatic collection, interloop collection you might find. And CT scan also might tell you any type of vascular injury if it has occurred. So these are the things which will tell you that bile duct injury already has occurred. CT scan will tell you bile duct injury has occurred. Now, next step is, I will not talk about scintigraphy later, I will talk MRC, VRCP later, I will talk. Then at this time, what is our aim? At this particular junction, we have only one aim, that is control external biliary fistula. How will you get it? By usually, I am not talking about, doctors are talking about doing endoscopic ultrasound, US guided. Very simple, your radiologist friend will come, put a small pigtail and it will take care. You might require 2-3 pigtails. Nowadays, 2 pigtails at a particular site. However, if there is a lots of peritonitis and no localized collection, then you can have a re-laparoscopy. Sometimes these patients refer to us, which is a huge drain, you can say, but still we do a CT scan, finding collection, we put a pigtail. So even drain presence and having bile not coming doesn't give any guarantee that there is no bile duct injury. So here all talk, whatever I have to talk is, my talk finishes here. So ultimate aim is, only aim is control fistula, nothing else. And then we have to see what we have to do. So intraoperative drain, as I said, might be very, very deceptive, because sometimes it doesn't work. When you need the maximum, it will not work. That is the principle of the drain. So we have to be this thing. Re-laparoscopy is something which is very nice thing. If you are having a generalized peritonitis, patient had luckily come to us. As a tertiary care center, usually don't get this patient. But if patient luckily has come, I have done twice in my own patients because of the some sectoral injury. And it is a wonderful operation. Laparoscopy can do lavage in any corner of the abdomen without, if you are doing open, you have to do midline incision. Lavage, open lavage is also required sometimes. So these are the basic principles. And once you have done this control fistula, then when to repair, what to repair, those are the, I don't think talk of this thing, but early bile duct repair, what to do as a surgeon, control biliary fistula, good hydration, antibiotics, empirical in the beginning, then culture-based. Electrolytes, imbalance have to be corrected, coagulopathy has to be corrected. Nutrition is so important, neglected in our country. 2 things we neglect, nutrition and pain. So we should be prepared nowadays for the nutrition. We feed bile. Once bile is not infected, we feed bile. Then reassurance. As I said, this is also part of our management. Before discharge, we should have a roadmap. If you are jumping for the MRC and MRCP, in the beginning, if you don't have a dynamic MR, it is of no use. Until unless you are making a control fistula, patient is well, patient is walking about, eating, doing everything, then you think of having a roadmap. Are you a proponent of early repair or late repair? That is not this talk. You have to, this patient will come with pictures like this. This is the MRCP. Read this MRCP. It has not helped in any way in management of the patient. CT scan, you do it, you made a control fistula. MRC, you need to have a management. You are doing endoscopy or something. We follow the technique of doing a simple HIDA investigation, by which we decide whether the minimum amount of bilirubin is entering the intestine. If it is, then endoscopy is at that particular juncture we do. We are not going blindly, because most of these bile duct, laparoscopic bile duct injury, they are the clips which are total clipping. Sometimes very lucky patient will have sectoral injury or slippage of the clip. So here you might be benefit, but once there is no communication at all, then all high endoscopy, I'm talking for the basics of the basics, that here is a patient, you could see that after 1 hour bile is draining and bile is going both way. This patient is going to have a maximum benefit by early ERCP. Not every patient is going to get benefited. You must remember, acute pancreatitis, biliary duodenal perforation, and duodenal bleed by the ERCP. So already one tired horse, and you are going to flog the tired horse. So before flogging, you get ready that I am 100% sure that these things is going to benefit. So this early repair, we are not doing, sir is not doing, SGPJ is not doing, PGI is not doing, AIMS is not doing, GBPAN is not doing. Some centers might be doing. So we are not doing. Our aim is good external fistula. So any exception may be, you have a clip, there is no biliary peritonitis. So I was listening Henry Bismuth. He said there is no minor bile leak. Each and every bile leak can produce peritonitis and kill a patient if he is not properly managed. Please remember this. So early repair has a lots of problem. So this is just slide for the everybody. I will just summarize by saying that I hope I have tried to cover what sir wanted. So early repair is no. First repair is again I will say the best repair. Sooner, this is a statement of sir, sooner is not better all the time. And you can see that management depends on time injury repair, type of injury, expertise available, and easiest, safest and elective option is to drain. I will repeat that you are going to save a life if you are putting a proper percutaneous drain and making a controlled fistula. That is the only aim in the beginning. And that after that, good referral. Good referral, I mean that don't refer to, where is my friend, I am referring to him just to oblige him. And you are going to increase the miseries. All these things we are facing. So earliest is not the best. Appropriate step taken after the injury is save the patient life and save surgeon also from the litigation. Early referral to the appropriate center, appropriate pace and appropriate person is a great service to the humanity. And let us start by saying that what is our aim? Primum non nocere. So we first do no harm. That is, thanks a lot for your kind attention. These are my friends involved in the management when there is any type of bile duct injury. They are gastroenterologists, intervention, and everybody. Thank you.
Patient is not well, if the vitals are not stable, if the abdomen is not settled, please do not discharge this patient. Keep her under your care, investigate her, a minimum of liver function tests and ultrasound. Even if ultrasound doesn't show any collection, but the patient is not improving in the next 4, 6, 8, 12 hours, do not hesitate to go ahead with cross-sectional imaging. Which could be CT or MRI. I personally prefer MR because most of these patients are young, so to avoid. May I request all the faculty to please come, Dr. Bhatt, Dr. Sahu, Dr. Nag and Dr. Yadav. So we have questions from the online centers, but before that, I would request the audience here. I can see some senior colleagues. Yes, since we are late and we have a lot of questions, I would request everyone to ask a specific question, and I'll request the related faculty to give a very specific brief answer. Dr. Abhinav.
Sir, I was just discussing this, Saurabh. Other than altered anatomy, unclear anatomy is also a cause for bile duct injury. So is there any guideline, like in ERCP we have guideline that we should do at least 200 supervised ERCP, this is AHG guideline, before we embark upon independent ERCP. So do you have similar guideline that this many supervised lab chole one fellow should do before taking over independent lab chole?
TD?
So in India, we don't have any this type of thing, but it is like most of the institutes nowadays, they are doing laparoscopic cholecystectomy. And if your resident is coming in the first year, and it is with you for 3 years, he is observing many consultants and he is continuously assisting. The problem with this operation is that there are certain people, they will do more injuries. There is evidence about that. That people who are arrogant, people who don't listen to other suggestions, like there are many things nowadays. Time out, before putting clip, you ask your sister in charge who is assisting you, and other people that should I clip now, your junior most. So all these things are basic. I think it's more about teaching basic stuff, teaching the teachers also. Because many times the teacher performing the laparoscopic cholecystectomy are also not following the basic steps to avoid bile duct injury. So these are the problems. And as you suggest that before clipping, I remember sir will stand behind us and he will say, prove it that it's any tubular structure, it's not the common bile duct, then only I will allow clipping. So this is very important. We are giving our resident, we said, before you clip, call us. So we are setting, suppose we go and see. CBS is the most important, one of them. Sometimes you are not able to achieve it. But if you are achieving the CBS and your another person, again sir had described cholecystography, somebody is coming and saying, oh, CBS we have achieved, now you can clip it. Obviously you are going to decrease. As I said, 0 bile duct injury probably is not going to happen. However, ICG has come, it is also going to decrease the bile duct injury in a properly trained person.
Like Dr. Sadiq used to say, there are two types of GI surgeon. One who has done bile duct injury and one who is to do
It is well established in published literature that bile duct injuries occur in the hands of surgeons who have large volumes and large experiences also. Monica.
It was a very nice discussion and nice sequence of lectures. One point I noticed which came up a bit new, that elimination of bile duct injury, which is a thing to be explored in future with the help of AI, I think. With superimposed various data images, I think in future it can happen. And another thing, Dr. Bhatt has mentioned that in asymptomatic cholecystectomy, which you have also quoted, that it has to be made 100% sure, otherwise it's a big price to pay for the asymptomatic cholecystectomy. So these are very important points. I think futuristic approach should be based on these approaches.
Dr. Sharma Sahab.
As far as the guidelines are concerned, there are no guidelines for ERCP in India. Anybody who passes his degree DM gastroenterology, he feels he is expert in doing ERCP, and he starts ERCP and creates complications. So guidelines are not there. As far as bile leak is concerned, I have an experience of managing more than 200 patients of bile leaks. Mostly these patients are cystic duct leaks, but then sometimes we find patients who have got partial bile duct injury. These patients who have got leak from the lateral wall of the bile duct, they usually don't respond to the simple placement of the stent. So we have to put more caliber of the stent, 2 stents, then they respond. Otherwise, most of the patients, they respond whether you put a 7 French or 10 French and do sphincterotomy.
Thank you. Saurabh, sorry. Yeah, please go ahead.
Will I just want to make one comment? Sir, is that we cannot eliminate all injuries. We can minimize by good training and good discipline. But what is more important is that if there is a problem, we must learn to do the right thing. Whether it is whether it's a bile duct injury, or whether it's a post-ERCP pancreatitis, or a post-ERCP bleed. We'll never, ever prevent 100%. But you must know what to do when something happens.
Sir, one thing I want to give for the resident who are doing residency in gastrosurgery, ERCP is not the primary modality or modality of choice for the post-cholecystectomy bile duct leak. It is only indicated if the continuity of the bile duct is maintained. So in complete transaction, there is no role of ERCP. So every patient with post-cholecystectomy bile leak should not be referred to gastroenterologist. It is both disease of gastrosurgeon and gastroenterologist. First, I think the aim is to control the bile fistula. First is to make it is a controlled fistula. Second, to see if the continuity is maintained or not by the MRCP or HIDA scan once fistula is controlled. If
I think, Dr. Saab, I think I'd just like to supplement that I think what you're saying is right, that you must have a controlled external biliary fistula.
Yes, sir.
The demonstration of continuity by non-invasive means is very unreliable. What you're talking about, complete transactions, both ends are separate. There are situations when both ends are leaking. And I have done ERCPs in them, and we find that although there is no continuity on cross-sectional imaging, dye is entering from the distal to the proximal segment, and the wire crosses. That is a situation that is not uncommon.
But
no, sir, what I'm trying to say is that what you are saying is that if the continuity is not there, don't try ERCP. I don't agree with that.
There is
in a very significant proportion of people where there is apparently no continuity, if it is done early enough, the wire crosses and the leak can be closed endoscopically.
Sir,
yes, in experienced hands and in with the proper precautions should be taken when there's a clearly system that is closed, there's intrahepatic bile duct dilatation, proximal segment is clipped and closed. There I would agree with you that one may not do. But a HIDA scan or any other non-invasive way of showing continuity, if it fails to demonstrate, does not mean there is no continuity and the endoscopist should not do.
So
that is the
I agree with you. There may be few cases where you can go, but if there is bile duct injury, lower end is always clipped with 2 clips. Anna, so you cannot.
I think there is no harm in
Saurabh?
patient to
Invasive procedure.
gastroenterologist.
It is invasive procedure and can produce a pancreatitis in bile leaking patient. So it should be indicated properly.
So actually, the most common type of injury is complete transection of the common bile duct. That is in literature, like in lab coli, we suspect that the CBD is the cystic duct, and we clip it and then we cut it. So, yeah. So plus, most of us have seen ERCP where the stent is below the only in the CBD, not crossing. They've put the CBD stent just because they've entered. So many of the ERCPs are not worthwhile doing. So what is the best way of seeing? First is draining and then doing a MRCP or a HIDA scan. So draining is very important. So that should be the message, that first is drain
so
the
in
bile.
summary, it is high index of suspicion. If there is suspicion, ultrasound followed by cross-sectional imaging. If there is collection, collection has to be drained. Then preferably an MRCP. HIDA is too non-specific and MRCP. And if ductal continuity is there, there is no debate that endoscopic intervention should be done because it will reduce the bile leak. It will even stop the bile leak in large number of cases. If MRCP doesn't show continuity, as Dr. Saraswat said, there may be continuity. So it depends on the expertise available. If you have an expert endoscopist available, you will still go for an endoscopy intervention, which will definitely show whether continuity is there or not. If there is no continuity, obviously there is no place and there is no role of stenting.
One point about the I would like to satisfy. The sensitivity of this isotope being used to pick up the bilirubin, even micro this milligram is picked up. So it is not an anatomical, but it gives an idea that still something is going on. I'm not saying that it is something which can replace MR. That's why we do MR. But MR is beginning of no use because of the lots of correction.
You see, TD, outside academic institutions, MR availability is much better than isotope scan. So for practicing surgeons, I think MRCP...
I just want to say that MR is required. Lots of MR, useless MR are coming regularly to us, and we are in pain to suggest that money invested in this. If you are giving a message,
Yeah, let's not go into those. Let us restrict ourselves to academic, that what should be done. That holds true for all investigations.
MR is done only when there is a controlled fistula, there is no bile inside the...
Yeah. Drainage of bile has to be the first step. There is no doubt. There is no doubt. Any of the young colleagues, residents would... So, Dr. Vyas, sir.
When you will remove this covered stent?
Yeah, we'll come to... There are questions related to that. We'll come to that. So, any of the students want to ask anything? Yes. Mic, please. Mic udhar de do. Udhar. Yeah, please stand up.
Yeah. Sorry. Line wala. Senior people
Hello. On post-op day 1, in the morning the patient, otherwise the patient is vitally stable, the pulse is 120, and as a surgeon, we have performed post-op day 1, and we suspect there might be a leak from duct of Ashka or somewhere around the right posterior sectoral duct. Sir, what should we do?
How we can do that it is duct of Lushka?
No, sir, we can there was one case, sir. There was one case. We suspected that it might be.
How do you suspect that duct of Lushka? You can't suspect the anatomy by looking at the patient. You can only suspect that there is something going wrong. Something going wrong after cholecystectomy is bile leak. Bile leak can be from anywhere. Unless you do a cholangiogram, how do you know where it is coming from?
Okay. But sir, if there is no facility of cholangiogram or a HIDA scan, so can we go for a re-laparoscopy on post-op day 1?
See, as Dr. Yadav said, and as I have been saying again and again, if you suspect that there is bile leak, you must document. And so it is ultrasound followed by cross-sectional imaging. If there is a collection, then first you have to drain that collection. then next step is to try to control it. So if your cholangiogram has shown that it is cystic duct stump leak or a cholecystohepatic duct leak, which would be very difficult on a cholangiogram to say, then when you are doing re-laparoscopy, you can tackle it. But the easier way than laparoscopy is to place an endoscopic stent. If it is a communicating duct which is leaking, endoscopic stent will stop that leak in a few days' time. The only place where endoscopic stent doesn't help is an aberrant duct leak, which is an isolated leak. Okay? So re-laparoscopy role is to drain the bile, not to control the bile leak. Bile leak can be controlled by endoscopic stenting, which is preferred.
Like, sir, if we role of BCD is in the case of a collection, na? So on post-op day 1, if you are not suspecting that much amount of collection.
How do you suspect the amount of collection?
In a USG, like we performed a USG,
Yeah,
there
so
was
if there is a significant
amount
collection,
was less.
you should drain it.
No, without a significant collection. Without a significant collection, but the vitals are not
If the
there.
patient is not well and ultrasound is showing a collection, it means that it is bile. You have to drain it.
And if
Small
you're not-
amount of bile also can kill the patient.
If you are not seeing the collection on day 1, why are you so anxious to do a re-laparoscopy? Wait and watch. If patient is asymptomatic, there is nothing on the first ultrasound. On day 2 or in a day or so, collection will be apparent, and that will be ample time to intervene rather than on the very first day going and actually resisting the urge to look and see rather than just wait and observe.
Okay.
You can wait and observe and see.
As I said, that CT scan with the if your ultrasound is
Index of suspicion has to be high and has to be persisting. Then you have to see. I think we have a lot of questions from the peripheral centers also, which I'd like to put to the experts. Professor S.P. Mishra from Allahabad has asked this question. Maybe Naresh, you can take it. What are the chances of a gallbladder stump or cystic duct cancer after prophylactic cholecystectomy? And why is GBC so high in Paima Indians?
Well, I don't know why it's so high in Paima Indians. I'm not aware of the reason for that. But yes, you can have whatever you leave back after cholecystectomy. A lot of times when it's difficult gallbladder, you find half the gallbladder left or a large amount of cystic duct left. Yes, theoretically, you can find a residual tumor there, if there is. But I think a good examination of the gallbladder with the margins and things like that should alert you to that, and you promptly will have to go back and complete your surgery appropriately.
Right, thank you. This is about gallbladder polyps, and maybe one of the surgeons can take that. Dr. Puneet Mehrotra and Dr. Ajay from Lucknow want to hear a bit more about gallbladder polyps. How frequent are they, and when do they warrant intervention?
Actually, I already told in my presentation, any gallbladder polyp larger than 1 centimeter should be treated because chances of malignancy are high. Some studies recommend even 6 mm size polyps should be taken out as a cholecystectomy. In that, I consider it should be reevaluated further if any polyp which is sessile, hypervascular, heterogeneous on enhancement, and where length and width ratio is less than 1, especially 0.8 or lower, then these cases has got high risk of harboring malignancy or developing malignancy. These cases should be taken out as a cholecystectomy. And if it is associated with the stone, that is also a further more
We often see patients who get referred when they have tiny hyperechoic, echogenic things in the wall. Those are things which have absolutely no sinister implication. So if you have something projecting into the lumen, yes, even if it's smaller, if you have associated stones, then perhaps you would go a little more aggressive. But if they do not have stones, 1 centimeter or something that is growing would be an indication for surgery.
Even sessile polyp also has got this thing.
Thank you.
If it is infiltrating into gallbladder, that is another factor.
For Dr. Sahu, you talked about endoscopic stenting for bile leaks. So as Dr. Sahu was asking also, and another Dr. Jayant Kumar Ghosh from Ranchi wants to know, after you've placed a stent, how will you decide that it is time to remove this stent? Plastic stent? Doctor wanted to know about a metal stent that has been placed. How soon should that be removed? And is cholangiography necessary before stent removal?
So basically the dictum is it depends upon the response to treatment, response after stenting. Plastic stents, when it is required, need to be removed or need to be changed every 2 to 3 months. If the response is not adequate, we put multiple plastic stents and see the response. Metal stents can be kept for longer period, 6 to 9 months, but the requirement is if the response is adequate, both the stents need to be removed yearly. There is some reports now, recent reports, if the bile duct is not dilated, if you are putting a fully covered metal stent and keeping the stent for longer period, there is a increased risk of development of fibrosis with the metal stents. So the stents need to be removed yearly. That depends upon the response. Now the question is whether we need to do cholangiogram again to establish there is leak or no leak. Cholangiogram is not routinely done in every cases before removing stent. When it is required, when you dealt with a very complex kind of biliary injury, so when you remove the stent, we need to know what is the anatomy. Cholangiogram may be done, but the plastic stent need to be removed yearly. If it is required, every 2 to 3 months it need to be changed till we are having adequate response. Metal stents can be kept for longer period, but it should be removed yearly if the response is good. If it is a minor bile duct injury, usually the response happens 2 to 4 weeks. Major bile duct injury, 4 to 8 weeks. So if the response is adequate, we can keep the metal stent for another 2 weeks and remove, but it should be removed yearly as per response.
Yeah, I think just add a little clarity to this. There are two issues. Are you dealing with a stricture, in which case you need prolonged stenting, multiple stenting, and stent changes? If you're talking of a leak, then you don't need long-term stenting. We're really talking of 4 weeks, or up to 8 weeks at the max. Second is that when you remove the stent, you will do a cholangiogram. Because just because the stent is there doesn't mean that the leak is healed. So pull out the stent, do a cholangiogram. If there's no leak, fine. If there is a leak, maybe you'll have to upsize your stent size or put more stents.
Yes, if you are putting a single plastic stents, incidence of blockage is more. But if it is there, you need to put multiple stents or a covered metal stent. So this is, you are dealing with a benign disease. So the incidence of blockage is not great, and we are keeping the stent for a shorter duration of time. So that is not great here because this is a benign disease. So the incidence of blockage is not significant with metal stent.
One last question now. How frequently is a spontaneous closure of bile leaks possible, noted? And what time frame could it happen on? That is one. The other scenario is that there is bile in the drains, you're doing an ERCP, you're going in, you're getting a cholangiogram and not picking up a leak. What could be the causes for such an observation and what to do in that situation? From Dr. Saraswat.
So answering the first question, it has been found that if there is no total transaction and if you have taken the proper care of the collected bile by doing a PCT or whatsoever procedure, then about 25 to 30% of these leaks, they close spontaneously. You have to do what we call is a medical endoscopy, a sphincterotomy, by putting some sort of small methyl relaxant on the regular basis. So that takes care. And about this, that I am talking about minor leaks that we call about Strasbourg, the type A. usually.
No, I mean, what I meant was without any intervention.
Without intervention.
No medications, no endoscopy, no surgery. Strictures, there is up to a 10% rate of spontaneous closure of bile duct leaks,
Yes,
possibly from minor ducts that has been reported. That's all that I want.
That can happen, but if there is a collection, the collection has to be taken care of.
No ifs, just
Yes.
spontaneous. Sure,
So
what you're saying is right.
second part was, sir?
I think
we
that
have
before
to,
the endoscopist, that if there is bile in the drains, but the ERCP is apparently negative, we do not find a leak, what could be the situations and what should we do then?
I have to answer to Strasberg type B injury, where it is found that it is not, as I showed in my sketch, it is not communicating with the main duct.
RPSD?
Yeah.
RPSD injury with the proximal end ligated, distal may be leaking.
Yeah.
So that is one scenario.
And there is one scenario. Second, very important, is that is most important, because you put a ERCP, it is not communicating. So here we always talk about more than 3 millimeter, more than other. It may drain one particular segment. Usually on the right side, segment 5 or segment 6 ducts they drain into this. And if it is not communicating, then
the management will go on. I mean, the scenarios we can be clear.
But very important is the person doing an ERCP has to ensure a good quality cholangiogram with a good view of the intrahepatic ducts.
Yeah.
Most often we just concentrate on the bile duct and the main hepatic duct. Unless you do a cholangiogram with the IHBR well seen, you can miss.
Exactly. I think that was the point, that the cholangiogram should be done at the papilla, at the hilum, maybe with balloon occlusion, so that minor leaks. One is a disconnected duct situation, which cholangiography will never pick up, as the RPSD injury with the ligated proximal end. On the other scenarios could be from, say, a Lushka duct or some minor duct, and you are not doing appropriate injection and you are missing a leak that is actually ongoing. These were the scenarios.
So again, I would just very briefly summarize the two topics. Asymptomatic gallstones, you may offer preventive cholecystectomy, you may not offer. But whatever you do, counsel the patient, document the counseling, and if you are advising cholecystectomy, make it 101% safe. What I do is, I don't recommend it, I don't advise it, but if the patient asks for it, I don't refuse it. After cholecystectomy, in every patient, suspect and keep in mind that there is a bile duct injury and make sure that it is not there. If you suspect, if there is any doubt, don't discharge the patient, investigate. If there is bile collection, drain the bile duct if possible, and then convert, as Dr. Yadav said, the acute bile duct injury and bile leak into a controlled external biliary fistula, so that the patient at least doesn't die and you have time to refer the patient to a proper place for further management. So with that, I think we have overshot the stipulated time by almost an hour, but I would like to thank all of you for coming, for participating in the discussion. I would like to thank all the online centers which have joined. Some of the very senior colleagues have joined, and I would like to thank all the panelists, the speakers, and my colleague, Dr. Saraswat. Over to LChem team.
Thank you so much, sir. So very good evening, everyone. And as we approach the close of this enlightening session, on behalf of Alchem Laboratories, it is my proud privilege to extend our heartfelt thanks to all who made the digest a meaningful and enriching session. A special thanks to our esteemed speakers, Dr. Naresh Bhatt sir, Dr. H.H. Nag sir, Dr. T.D. Yadav sir, and Dr. Manoj Kumar Sahu sir for sharing their valuable insights and clinical wisdom on two very relevant topics: what to do in case of incidental gallstones and bile leak after cholecystectomy. Our sincere gratitude to our moderators, Dr. V.K. Kapoor sir and Dr. Vivekanand Saraswat sir, for steering today's discussion with such clarity and depth. Since this program is part of a larger metaphysical series being conducted across 30 cities, we extend our appreciation to all the moderators for leading the sessions in their respective cities and enriching this pan-India initiative.
We also take this opportunity to thank our academic partner, MGM Medical College and Hospital, Jaipur, for their collaboration and continued support in this educational endeavor. And we would also like to extend our heartfelt thanks to the event partners, Banyan Tree Communication, Alchem IT team, admin team, sales and marketing team across the country for their untiring efforts for making this first edition of Digest a grand success. And we would also like to thank our hotel team and audiovisual team across various centers for their valued support for this Digest program. Today we are having across almost 1,000 plus delegates attending this program physically at 30 centers across the country, and about over 650 participants watching it online. A big thank you to all the participants for joining us this evening and making the session truly interactive and thought-provoking. Before we close, a quick reminder to all the participants to download their certificate. All they need to do is to refresh the page and click on the download certificate button and it will be downloaded. The entire session of this Digest program of today will be archived on digestgastro.com, which can be referred for future references. And we look forward to meeting you again in the next Digest program. Thank you all and have a pleasant evening ahead. Thank you so much. Thank you so much. Thank you.